Assalamu alaikum. My name is Zaitoon Zafar and I'm a final year medical student at Shalamar Medical and Dental College. This presentation is going to be about a tool named PreoDIT, designed to judge a difficult thyroidectomy preoperatively. I have no conflicts of interest to declare or disclose. A thyroidectomy is nowadays known as a relatively safe and routine procedure, but this was not always the case. Up until the early 20th century, it was considered horrid butchery and was even forbidden by the French Medical Society, owing to its very high mortality rate and an equally high morbidity rate. This remained the case until Theodore Kocher arrived on the scene, and with his aseptic techniques and manipulation of the vascularity of the thyroid gland, he reduced the mortality rate from a high of 75% to a negligible rate of 0.5%. For his efforts and his work, he was awarded the Nobel Prize in Physiology and Medicine in 1909. Despite it being one of the safest contemporary surgical procedures, a thyroidectomy is not without its challenges. Graves' disease, one of the most common presentations of thyroid disorder, has complications up until 30% of the time. Hashimoto's up to 40% of the time. The bigger the gland, the more blood loss and longer operative time. The more invasive the carcinoma, the more difficult its resection. To deal with these challenges, Schneider and his colleagues came up with a thyroidectomy difficulty scale in 2014. They identified 4 factors relating only to the gland, which had to be rated on a Likert scale of 1 to 5 during the surgery. And what they found was that their thyroidectomy difficulty scale correlated with the operative times of the procedures. This was necessary research, but it had its limitations. First and foremost, the scale only measured the difficulty of the thyroid, the difficulty of the procedure during the operation or as a post-operative assessment. Second, it disregarded any and other factors and only stuck to the vascularity of the gland, the friability of the thyroid gland, the mobility, and the size of the thyroid gland. It did not pay attention to any of the factors related to the patient or the malignancy. So what was needed was a tool that judged the difficulty, the upcoming difficulty, before the patient was on the table, and which brought together any and all factors that may contribute to the difficulty of the upcoming procedure. So we came up with the preoperative difficulty index for thyroidectomy, the PreoDIT. How we went about designing the tool is, first of all, we conducted a literature review, and then we assembled a focus group of 8 experts with extensive experience in thyroid surgery. And we came to a conclusion of 12 factors, ranging from factors related to the thyroid gland, which included the inflammation, the toxicosis, the extension of the goiter, to factors relating to the malignancy, the staging of the carcinoma, the type of the carcinoma, and factors related to the patient themselves. What we found was that primary thyrotoxicosis was the most difficult to deal with. So after we had identified all factors that were common to both the literature and to the focus group, we set about building a consensus on the relative value of these factors. And we did this by conducting an E-Delphi. And what we found was that primary thyrotoxicosis was the most difficult to deal with out of all the thyrotoxicoses, and that an intrathoracic goiter single-handedly is the most difficult presentation of any patient with the highest score of 11 on the board, and that the carcinoma staging was directly proportional to how difficult it was going to be operated on. The carcinoma type most difficult to deal with is an anaplastic carcinoma. And then we also found that if a patient was unable to move their neck, they were going to be very difficult to operate on. And the same for if a patient had a short neck or if the patient had a high BMI. Once we had determined the content validity of the factors, we wanted to assign grading to the scores. So the maximum score on PreoDIT can be a 28, but if you score less than 1 or a 1, you get a grade of 1. If you score from 3.1 to 5.9, you get a grade of 3. If you score more than 9, if the patient scores more than 9 on the PreoDIT, they get a grade of 5, which is the highest grade. Now, once we were done with the making of the tool, we wanted to test its validity and reliability on actual patients in a hospital setting. So what we did was we enrolled 513 patients undergoing thyroidectomy for multiple reasons, and we assigned them their preoperative score based on their presentation, based on scans, and we did not reveal the score to the surgeons. What the surgeons had to do was they had to fill out a score once the procedure had been done, and they had to rate the difficulty of the procedure they had just performed on a Likert scale of 1 to 5. Apart from these two scores, general demographics and parameters related to postoperative factors such as blood loss, hospital stay, and complications were recorded. These were the demographic parameters that we recorded, ranging from the clinical and histological diagnosis to the type of surgery performed. These were the outcome parameters that we measured. We measured the length of the surgery, the length of the hospital stay, post-op. We measured whether they had transient or permanent hypocalcemia, transient and permanent nerve damage, wound infection, hematoma and seroma formation. And we even measured recurrence, ranging of a minimum period of 6 months to a maximum period of 7 years. This was all done amongst our population of 513 patients. Now we set out to determine whether our scoring system was reliable or not. And we conducted the intra-rater and inter-rater reliability testing. The intra-rater, meaning which was to judge the correlation between rater 1 and rater 2. So patient 1 and patient 2, we found that it was almost perfect for both our scoring and for our grades. And the inter-rater reliability, which was to correlate and judge how many pairs of raters gave exactly the same score. And this was also almost perfect, almost a score of 1 on both the pre-audit scoring and the pre-audit grading, compared to the thyroidectomy difficulty scale of 2014, which is 0.8 and 0.7. We also found that the pre-audit scores, which we had assigned to the patients, in addition to the grades, also correlated strongly to the scoring that the surgeons had entered blindly following their procedures. We found that there was a strong association. We also measured the p-value of each and every coefficient we received as to determine whether the numbers we were receiving were random or coincidental, and they were not. The most important statistic of this tool was whether the pre-audit determined how many complications there were going to be. And we found a strong association with very low p-values. And we determined that the pre-audit score did actually predict how difficult the surgery was going to be and how many complications were going to arise. And with the p-value, we also were confident in the fact that the numbers we received, the correlation coefficients that we received, were not just random and were not coincidental. And hence we concluded that the pre-audit score successfully judged the operative time, the blood loss, and the complications. And hence this tool provides information which could be useful for surgeons to preoperatively optimize and manage their teams, their OR resources, and to know what's coming their way. So to summarize, the PreoDIT is a preoperative difficulty index for thyroidectomy. It is a novel, reliable, content-valid, and valuable tool used to predict, plan, and perform. All one has to do is identify factors that complicate a thyroidectomy, ranging from thyrotoxicosis to carcinoma staging, to the BMI of the patient. One then has to determine the PreoDIT score of their patient and hence have preferred outcomes in operative time, blood loss, and complications. Thank you so much for listening. If you have any questions, please don't hesitate in asking. This study was also presented at the American College of Surgeons Clinical Congress of 2020, and more information about the tool can be found on this website. Thank you so much.